There is a conversation that happens in hospitals every single day, and most seniors are never prepared for it. A doctor recommends a surgery. The family is worried. The senior is scared. And almost nobody in that room has been told the full picture of what the research actually says about certain surgical procedures in older adults, what the real risks are, what the alternatives might be, and what questions should absolutely be asked before anyone signs a consent form. Today we are going to have that conversation, because the information we're about to share could genuinely be the difference between a decision you feel confident about and one you regret. Stay with us until the very end, because the fifth surgery on this list is the one that surprises people the most, and it involves a procedure that is recommended far more commonly than most people realize. Before we go any further, there is something critically important to establish. This video is not telling any senior to refuse surgery. Surgery saves lives every single day, including in elderly patients. What this video is about is informed decision-making, which is one of the most fundamental rights any patient has and one of the most frequently overlooked aspects of healthcare for older adults. The medical literature is very clear that certain surgical procedures carry significantly higher risks in patients over 70, 75, and 80 than they do in younger patients, and that in some cases, non-surgical alternatives can produce comparable outcomes with far lower risk. Every senior, and every family member supporting a senior, deserves to know this before they say yes to an operating table. Let's start by understanding why surgery in general carries higher risk after a certain age. The answer isn't simply that older bodies are weaker, though that is part of it. The deeper answer involves a concept called physiological reserve, which is the body's capacity to respond to the additional stress of surgery, anesthesia, blood loss, infection risk, and the physical demands of recovery. In younger adults, physiological reserve is typically abundant, meaning the body can absorb the shock of a major surgical procedure and bounce back. After 70, this reserve has often diminished significantly, and it diminishes further with each additional decade. When surgery is performed on a body with limited physiological reserve, the margin for error is much smaller, the complications are harder to recover from, and the recovery process itself can produce secondary problems that compound on each other. This is not a reason to avoid all surgery. It is the reason why understanding the specific risk profile of any proposed surgery becomes genuinely critical in older patients in a way that it simply is not in younger ones. There is also something called frailty, which is increasingly recognized in geriatric medicine as one of the most important predictors of surgical outcome in older adults. Frailty is not simply being old or being thin. It is a specific clinical state characterized by reduced strength, reduced activity level, unintentional weight loss, exhaustion, and slowness of movement. Research has consistently shown that frail patients, regardless of their exact age, face significantly higher rates of complications, longer hospital stays, higher rates of institutionalization after surgery, and higher mortality following major surgical procedures. Many surgeons now use formal frailty assessments as part of the pre-surgical evaluation for older patients, but not all do, and many patients and families are never told that frailty is a factor being considered or assessed at all. Another layer that rarely gets discussed in pre-surgical consultations is the risk of post-operative delirium, which is one of the most common and most serious complications of major surgery in older adults. Delirium is a state of sudden confusion, disorientation, and altered awareness that can develop within days of surgery, and in elderly patients it is both common and consequential. Research shows that post-operative delirium occurs in a significant percentage of older surgical patients, and that when it does occur, it is associated with longer hospital stays, higher rates of complications, accelerated cognitive decline, and in some cases permanent changes in cognitive function. Many families are completely blindsided by delirium when it occurs because nobody warned them it was a possibility. Understanding this risk before surgery allows families to prepare, to advocate for appropriate monitoring, and to ask the surgical team what specific steps they take to prevent and manage delirium in elderly patients. It is a conversation that should happen before every major surgery in a patient over 70, and it almost never does unless someone specifically asks. The cumulative effect of multiple surgeries on an elderly body is also something worth understanding. Seniors who have undergone previous major surgeries may have reduced physiological reserve as a result, meaning that each subsequent major surgical procedure carries incrementally higher risk than it would in a patient with no surgical history. The concept of cumulative surgical stress is not widely communicated to patients, but it is a genuine factor that experienced geriatric surgeons consider when evaluating whether a proposed procedure is appropriate for a patient who has already been through significant medical interventions. If a senior has had multiple major surgeries in recent years, asking the surgical team directly how this history affects the risk assessment for the current proposed procedure is an important and entirely appropriate question. The role of nutrition in surgical outcomes for seniors is another area that receives far less attention than it deserves. Malnutrition and nutritional deficiency are significantly more common in older adults than most people realize, and poor nutritional status substantially increases surgical risk and impairs recovery. Research has shown that nutritionally depleted patients face higher rates of wound complications, infection, delayed healing, and longer recovery times after surgery. In elective surgeries, taking the time to optimize nutritional status before the procedure, with guidance from a registered dietitian, can meaningfully improve outcomes. Patients and families should feel empowered to ask whether their loved one's nutritional status has been assessed as part of the pre-surgical evaluation and whether any nutritional optimization is recommended or possible before proceeding. Cognitive status before surgery is equally important to understand as a predictor of outcome. Seniors who have any degree of mild cognitive impairment, even if not formally diagnosed with dementia, face higher risks of postoperative delirium, greater difficulty following recovery instructions, and reduced ability to participate in post-surgical rehabilitation. Pre-surgical cognitive assessment is increasingly recommended in geriatric surgery guidelines but is not yet universally practiced. If a senior or their family has noticed any memory concerns, confusion, or changes in cognitive sharpness before a surgical consultation, making the surgical team aware of this is genuinely important, not to disqualify the patient from necessary surgery, but to ensure that appropriate precautions, support structures, and monitoring are in place for both the procedure and the recovery period. The first surgery worth discussing in this context is open heart surgery in very elderly patients, particularly in those over 80. Procedures like valve replacement and bypass surgery have saved enormous numbers of lives and are genuinely necessary in many situations. But the risk profile of open heart surgery changes substantially as patients move through their 70s and into their 80s, particularly when other health conditions are present. The research on outcomes of open heart surgery in patients over 80 consistently shows higher rates of stroke, prolonged delirium, kidney failure, extended intensive care unit stays, and mortality compared to younger patients. The key questions a senior or their family should be asking in this situation include whether minimally invasive alternatives are available, what the realistic outcomes look like specifically for a patient with their health profile, what the medical management alternative would look like, and what the surgeon's specific experience and outcomes data are for patients in the same age and health category. These are not unreasonable questions. They are the questions that any well-informed patient has the right to ask. The second surgery worth understanding in this context is major spinal surgery, particularly multi-level spinal fusion in older adults. Back and spinal pain is extremely common in seniors, and the recommendation for surgical intervention, including fusion of multiple vertebrae, has increased significantly in recent decades. But the research on outcomes for complex spinal surgery in older adults tells a more complicated story than most patients are given. Studies have shown that while some seniors benefit substantially from spinal surgery, others experience limited improvement in pain or function, and a meaningful percentage experience serious complications including blood clots, infection, hardware failure, and the need for additional surgeries. What makes this particularly important is that for many seniors with degenerative spinal conditions, a combination of physical therapy, pain management, activity modification, and other non-surgical approaches can produce meaningful quality of life improvements without the risks of major surgery. The question is not whether spinal surgery is ever appropriate for seniors, because it certainly can be, but whether every senior being recommended this procedure has been fully informed of the evidence on both surgical and non-surgical options for their specific situation. The third surgery worth discussing carefully is aggressive cancer surgery, particularly procedures involving the removal of significant portions of internal organs in very elderly patients with advanced cancer. This is perhaps the most emotionally charged area on this list because cancer diagnosis creates enormous psychological pressure to do something, to treat aggressively, to fight. But there is a growing body of research in oncology and geriatric medicine exploring the concept of surgical aggressiveness in elderly patients with certain cancers, and what it consistently shows is that aggressive surgical procedures in very elderly or frail patients with advanced cancers do not always extend meaningful life and can in some cases significantly reduce quality of life in the time that remains. This is not an argument against cancer treatment. It is an argument for ensuring that elderly patients with cancer have honest, individualized conversations about what aggressive surgical treatment is realistically likely to achieve in their specific situation, what palliative and quality of life-focused alternatives exist, and what the patient themselves, not just the family and not just the doctor, actually wants when they are given complete information. The fourth surgery involves emergency surgery performed in elderly patients who are already in very poor health. There are situations where emergency surgery is absolutely necessary and life-saving, and those situations should not be confused with what we're discussing here. The concern arises when elderly patients in poor baseline health face pressure to undergo emergency surgical procedures whose outcomes in their specific clinical situation are very poor. Research in emergency and geriatric surgery has shown that certain emergency procedures performed on very elderly, frail, or critically ill patients have mortality rates and complication rates that many families and patients are not clearly told before decisions are made. Emergency situations create time pressure that can work against the informed decision-making process, and families of elderly patients should know that it is always appropriate to ask a surgeon directly what the realistic expected outcome is for a patient with their loved one's specific health profile, even in urgent situations. The fifth surgery, and the one that surprises the most people, involves certain procedures related to advanced dementia. When a patient has advanced dementia, the question of whether surgical procedures including feeding tube placement, hip repair after fracture, and other major interventions will genuinely improve or extend meaningful quality of life becomes one of the most important and most frequently avoided conversations in elder care. Research in geriatric medicine and palliative care has shown that certain surgical and procedural interventions in patients with advanced dementia often do not produce the quality of life or survival benefits that families hope for, and can in some cases cause additional distress and complications in a patient who is unable to communicate their experience or participate in their own recovery. This is an area where advanced directives, conversations about goals of care, and the involvement of palliative care specialists can be genuinely life-saving in the truest sense, preventing interventions that extend suffering rather than life in any meaningful sense of the word. So what should a senior or their family actually do with this information? The answer is not to refuse surgery out of hand. The answer is to become a genuinely informed participant in every surgical decision. This means asking the surgeon several specific questions that every patient has the right to ask and every surgeon should be willing to answer. What are the realistic expected outcomes of this surgery specifically for a patient with my age and health profile? What are the risks of serious complications, extended recovery, or death? What are the non-surgical alternatives and what does the evidence say about their effectiveness compared to surgery in cases like mine? What does recovery realistically look like, including the realistic timeline, the support required, and the probability of returning to the level of function I had before surgery? And if I decide not to have this surgery, what is the realistic trajectory of my condition with medical management alone? Seeking a second opinion is also something every senior should feel not just permitted but actively encouraged to do before agreeing to any major surgical procedure. Second opinions are a fundamental part of good medical practice. They are not an insult to any surgeon, and they are associated in research with meaningful rates of change in diagnosis or treatment recommendation. Any surgeon who discourages a patient from seeking a second opinion is not behaving in accordance with the standards of patient-centered care. It is also worth knowing that many hospitals now offer geriatric surgery programs or pre-surgical geriatric assessments specifically designed to evaluate older patients' overall physiological status, frailty level, cognitive function, and support systems before major surgery. These assessments can provide both the surgical team and the patient with a much clearer picture of what to realistically expect, and they represent exactly the kind of individualized evaluation that the research supports as best practice for surgical decision-making in older adults. Before we close, it is essential to be clear that this video is for general educational awareness only. It is not medical advice, it is not a recommendation to refuse any specific surgery, and it is not a substitute for a thorough conversation with qualified physicians who know the individual patient's complete health history. The goal of this video is to make sure that seniors and their families go into surgical conversations with the right questions, the right expectations, and the confidence to be active participants in decisions that profoundly affect their lives. If this video gave you or someone you love the information needed to walk into a medical consultation better prepared, please share it, because this is exactly the kind of awareness that can change the outcome of a conversation that matters enormously. If you found this video helpful, please like it and subscribe to Dr. William Hart Health for more videos like this every day.